Welcome, everyone. Today, we'll explore vascular health and hypertension management, two major areas in medical surgical nursing that connect nearly every body system. By the end of this session, you should be able to identify and differentiate common arterial and venous disorders, explain nursing assessments that reveal early vascular problems, discuss strategies for preventing hypertension and vascular complications, apply evidence-based interventions for patient education and safety, perform accurate medication and dosage calculations related to cardiovascular care. Understanding these topics allows us to protect vital organs, promote circulation, and prevent long-term damage in our patients. Let's get started with arterial disorders, the pump, pipes, and pressure foundation of circulation.
Now, let's talk about intermittent claudication and peripheral artery disease, or PAD. Intermittent claudication refers to muscle cramping or aching pain in the legs that occurs during exercise and is relieved by rest. This happens because the leg muscles aren't getting enough oxygen, what we call arterial ischemia. As soon as the person stops walking and oxygen demand decreases, the pain goes away. This symptom is a hallmark of peripheral artery disease, which is a chronic condition caused by fatty plaque buildup that narrows the arteries and limits blood flow to the limbs. PAD doesn't just affect the legs, it's a red flag for widespread atherosclerosis and a higher risk for heart attack and stroke. Let's look at a quick scenario. A 67-year-old patient reports calf pain that begins after walking and disappears when they rest. This is classic intermittent claudication, pain that's triggered by activity and relieved by rest. Here's a good comparison. Arterial pain occurs with activity and improves with rest, whereas venous pain tends to improve with movement or elevation. I like to tell students that intermittent claudication is the angina of the legs. When walking, muscles call for more oxygen, but narrowed arteries can't deliver enough blood, so the muscles cramp, just like the heart does when it's under strain. Recognizing this symptom early allows nurses to advocate for further vascular testing, encourage smoking cessation, and promote exercise therapy to improve collateral circulation. So remember, pain with walking that's relieved by rest means arterial, not venous.
Let's move on to an essential part of PAD management, improving circulation through walking. Exercise is actually one of the most effective non-pharmacologic treatments for peripheral artery disease. When patients walk regularly, they stimulate the development of collateral circulation. These are small alternate blood vessels that form new pathways for oxygen delivery around blocked arteries. Over time, this increased blood flow can significantly reduce claudication pain and improve walking endurance. As nurses, our role is to teach and encourage interval walking. That means the patient walks until they feel moderate discomfort, around a 3 on a pain scale of 5, then stops to rest until the pain subsides and resumes again. This walk-rest-walk pattern strengthens the legs without overexerting them and trains the muscles to use oxygen more efficiently. Let's connect this to a clinical scenario. A 64-year-old patient with PAD reports leg pain when walking. What should we tell this patient? We should encourage regular moderate walking. Don't avoid it. Stopping activity altogether will actually make circulation worse. Instead, structured walking sessions several times a week help build endurance and promote arterial health. You can reassure patients that mild discomfort is normal. It's the body's way of signaling low oxygen. The key is consistency. Start with short distances, rest as needed, and gradually increase duration. In a way, you can think of this as cardiac rehabilitation for the legs, a progressive training program that restores function and confidence. As nurses, our encouragement and education are often what keep patients motivated to stay active and heal.
Now let's take a closer look at subclavian artery stenosis, most common arterial blockage, and how we recognize it at the bedside. Normally, blood pressure readings in both arms should be fairly equal, maybe a few points apart. But if we see a consistent difference of more than about 15 to 20 millimeters of mercury, that's a red flag for an upper extremity arterial blockage. In this condition, one of the subclavian arteries, the major vessels supplying the arms, becomes narrowed by atherosclerosis. The affected arm receives less blood flow, so it may feel cooler, paler, or even weaker. Because of increased resistance upstream, that arm's pressure can sometimes appear slightly higher, even though actual perfusion is lower. The opposite arm usually looks warmer and more normally colored. Let's think through a clinical example. You measure a patient's BPs and find the right arm is cool to the touch with a pressure of 140/90, while the left arm is warm at 120/80. What should you do? You should suspect a subclavian artery occlusion on the right side and notify the provider immediately. Do not keep rechecking or use that arm for blood draws or IVs until further evaluation is complete. This finding can even progress to what's called subclavian steal syndrome, where blood intended for the brain is diverted down the arm during activity, potentially leading to dizziness or neurologic symptoms. So, the key takeaway is this: always compare arm pressures in vascular assessments, document significant differences, avoid procedures on the affected limb, and escalate promptly. That simple comparison could prevent limb ischemia, or even a stroke.
Next, let's discuss how and why we use a Doppler ultrasound to assess circulation in patients with PAD. When a peripheral pulse, such as the dorsalis pedis or posterior tibial, is weak or not palpable, we never assume that it's absent. Instead, we verify it using a Doppler device. The Doppler converts blood flow into audible sounds, so even when you can't feel a pulse with your fingers, you can hear it. This is especially important in patients with arterial disease, where blood flow is often reduced but not completely blocked. Here's how it works. Apply a small amount of ultrasound gel to the pulse site, place the probe at about a 45-degree angle, and move slowly until you hear that characteristic whooshing sound, which indicates blood flow. The Doppler is far more sensitive than palpation. It can detect very faint flow that we might otherwise miss. Let's apply this to a clinical situation. A 65-year-old patient with PAD has no palpable pulse in the left foot. What's your next step? You should immediately use a Doppler to assess circulation. If the Doppler still fails to detect flow, treat it as an emergency. This could mean arterial occlusion and possible limb ischemia. Notify the provider right away. A key point to teach students: an absent pulse is an emergency until proven otherwise. Mark the spot where you find the Doppler signal so your colleagues can reassess easily, and always document precisely. For example, Dopplerable pedal pulse, non-palpable by touch. Using the Doppler isn't just a skill, it's a safeguard that prevents us from missing a critical loss of perfusion.
Now, let's step back and look at what's really required for adequate arterial circulation. In every patient, blood flow depends on three main components: the pump, the volume, and the pipes. First, we need an effective cardiac pump. The heart must generate enough force to push blood forward through the vessels. Even if arteries are wide open, a weak heart, like in heart failure, can't provide adequate perfusion. So, no matter how healthy the arteries look, if the pump is failing, tissues won't get enough oxygenated blood. Second, we need sufficient blood volume and proper vascular tone. Blood pressure is all about volume and resistance. If the patient is hypovolemic from bleeding or dehydration, or if the vessels are excessively dilated, like in septic shock, pressure drops and perfusion suffers. On the other hand, if vessels constrict too tightly, flow can also be compromised. So, balance is key. And third, we need patent, healthy vessels. The arteries must be open and flexible. Atherosclerosis, or plaque buildup, narrows the lumen, and arterial stiffening makes it harder for the heart to push blood through. That's why PAD and hypertension so often travel together. They both strain the system. Let's tie this together with an analogy I like to use. Imagine a garden hose. The faucet represents the heart's pumping pressure. The water inside is your blood volume, and the hose itself is your arteries. If the faucet isn't turned on enough, that's a weak heart. If there's not enough water in the tank, that's hypovolemia. And if the hose is kinked or clogged with debris, that's atherosclerosis. Any one of these problems results in a weak trickle at the end, exactly what happens when circulation is impaired. So, when assessing perfusion, always think pump, volume, and pipes. It's a simple framework that explains almost every circulation problem you'll encounter.
Now that we've covered arterial circulation, let's shift our focus to the venous side of the vascular system, the part responsible for bringing blood back to the heart. Venous disorders are all about stasis, blood that isn't moving efficiently. When venous return slows, pressure builds in the legs, leading to swelling, heaviness, and sometimes ulcers. The most common conditions you'll encounter are varicose veins, chronic venous insufficiency, CVI, and deep vein thrombosis, DVT. Let's think about the key difference between arteries and veins. Arteries rely on the heart's pumping power, but veins depend on one-way valves and muscle contractions, especially those in the calves, to push blood upward against gravity. When valves weaken or when a patient is immobile, blood pools in the lower extremities, causing congestion and inflammation. Typical risk factors include prolonged standing or sitting, obesity, surgery, immobility, and estrogen therapy, all of which contribute to venous stasis. From a nursing perspective, our goals are prevention and symptom control. We want to promote mobility, compression therapy when appropriate, and hydration to keep blood moving. You'll often hear me say, veins love movement. Simple actions like ankle pumps, walking, or leg elevation are incredibly powerful in preventing venous complications. As nurses, we must also assess for early warning signs: leg swelling, warmth, skin discoloration, or pain that worsens when standing. These findings may indicate chronic venous disease or even a developing clot. So, remember, arteries deliver blood out, veins bring it back. When the return system fails, pressure builds, and tissue health suffers. Our job is to keep that venous blood moving, safely and consistently.
Now, let's talk about two closely related topics: compression therapy and varicose vein prevention, conditions that affect many of our patients and even us as nurses. Varicose veins develop gradually from chronic venous pressure. Jobs that require long periods of standing or sitting, like nurses, teachers, warehouse workers, or office staff, put extra strain on the veins in the legs. When the calf muscles stay inactive, blood pools in the veins, the valves stretch, and over time, those familiar twisted, bulging veins begin to appear. The good news is that prevention is simple and effective. It's all about movement and compression. Encourage patients to take short walking breaks, perform calf raises, or march in place to keep the leg muscles working. If sitting for long periods, they can flex and extend the ankles or rotate the feet every few minutes to keep circulation moving. Other helpful habits include avoiding crossing the legs, elevating the legs during breaks, and wearing graduated compression stockings if recommended. Let's review how to use compression stockings correctly. They should be applied first thing in the morning before swelling starts, worn throughout the day, and removed at night. The stockings should fit smoothly and evenly, no wrinkles, folds, or rolled tops, since those can act like a tourniquet and injure the skin. Compression is graduated, tighter at the ankle and looser higher up, helping push blood back toward the heart. Remind patients to check their skin daily, keep their legs clean, dry, and moisturized, and watch for any redness or irritation. If stockings are hard to apply, suggest using donning aids or getting help from a caregiver. And very importantly, patients with arterial disease should not use high-pressure stockings until cleared with an ankle brachial index ABI test, since compression can worsen poor arterial circulation. For example, if a 46-year-old warehouse worker asks how to prevent varicose veins, the advice is simple: move often, elevate when you can, and wear compression if recommended. Remind patients that once varicose veins form, they won't disappear without medical treatment, so prevention is the best strategy. Whether it's through movement, elevation, or compression, our role as nurses is to teach and model these habits to help patients protect their veins for life.
Let's turn our attention to chronic venous insufficiency, or CVI, and how nurses can guide patients in managing it effectively at home. CVI develops when the valves inside the leg veins are damaged or weak. These valves normally act like one-way doors, keeping blood moving upward toward the heart. When they fail, blood flows backward and pools in the lower legs. Over time, this leads to chronic swelling, aching or heaviness, brownish skin discoloration, and in more advanced stages, venous ulcers. The cornerstone of CVI management is graduated compression therapy. Compression stockings gently squeeze the legs from the ankles upward, promoting venous return and preventing blood from stagnating. This reduces edema, improves circulation, and helps prevent ulcer formation. The key is consistency. Stockings must be worn every single day, ideally put on in the morning before swelling begins and removed at bedtime. Now, let's look at a quick clinical example. A 59-year-old man with chronic venous insufficiency asks how he can best manage his symptoms at home. The most essential instruction you should give him is: wear your prescribed compression stockings every day as directed. Teach him to apply them smoothly without wrinkles, to avoid creating areas of high pressure that can injure the skin. In addition to compression, encourage other helpful habits. Elevate the legs when resting, walk regularly, avoid prolonged standing or sitting, and maintain a healthy weight. These actions all work together to improve venous return. It's important to be empathetic when teaching this. Compression stockings can be uncomfortable, especially in warm weather, so acknowledge that and offer practical tips, like using donning aids or getting help from a caregiver. Finally, emphasize skin care. CVI causes the skin to become thin, itchy, and fragile. Encourage daily moisturizing and inspection for cracks, rashes, or ulcers. Without compression and good skin care, gravity will take over, swelling will worsen, and ulcers will be harder to heal. So, remember, movement, elevation, and compression are the 3 pillars of venous self-care.
When assessing patients with chronic venous insufficiency who develop venous leg ulcers, it's crucial to perform a complete and detailed vascular assessment. Begin with pain. Note the location, intensity, and character. Venous ulcers often cause mild aching pain that improves with leg elevation, but severe or worsening pain may suggest infection or an arterial component. Compare skin temperature between both legs. The affected leg may feel warm due to inflammation or cooler if edema interferes with blood flow. Always check pedal pulses in both legs. Pulses should be present. If they're weak or absent, that's a red flag for arterial disease, which changes how we approach compression therapy. Evaluate mobility. Limited movement worsens venous stasis and delays healing. And document ulcer characteristics such as size, depth, exudate, color, and surrounding skin condition. And this part is very important. Document findings clearly. Remember that pressure ulcer staging does not apply to venous ulcers. Instead, describe the wound's appearance. For example, shallow, moist, granulating with irregular edges. Finally, consider the big picture. How is this ulcer affecting the patient's daily life? Are they able to elevate their legs, walk, and perform self-care? These functional details guide our plan of care and help us promote true healing, not just wound closure. So in summary, assess thoroughly, describe accurately, and document clearly. Those details are what ensure safe, effective venous ulcer management.
Venous ulcers are one of the most common and challenging complications of chronic venous insufficiency. They usually form around the ankles, especially near the medial malleolus, due to chronic venous hypertension and edema. These ulcers are often shallow, irregular, and draining, surrounded by brown, discolored skin from years of poor circulation. Healing can take months unless venous pressure is relieved. Our key nursing priorities are simple but powerful: elevate, compress, and protect. Leg elevation is the fastest way to reduce swelling and improve venous return. Encourage patients to elevate their legs above heart level several times a day, in bed or in a recliner. Remember the rule: veins up, arteries down. Compression therapy maintains gentle pressure to prevent blood pooling. Stockings or wraps should be smooth, wrinkle-free, and applied in the morning before swelling begins. Pair this with mobility and calf muscle exercise to keep blood moving. For wound care, follow moist wound healing principles. Keep the ulcer clean, protected, and debride dead tissue if ordered. Always safeguard fragile surrounding skin. Finally, emphasize patient education. Healing takes consistency. Daily elevation, proper compression, and regular skin checks. Encourage patients to report early signs of infection, such as redness, warmth, or increased drainage. The bottom line, consistent elevation, compression, movement, and gentle skin care are the cornerstones of venous ulcer management.
Now, let's look at a particularly high-risk situation when immobility and estrogen therapy combine to increase the risk for deep vein thrombosis, DVT, and pulmonary embolism, PE. Estrogen-containing medications, like oral contraceptives or hormone replacement therapy, raise clotting factor levels, creating a hypercoagulable state. After surgery, when patients are immobile, venous blood flow slows dramatically. That's venous stasis. Add in vessel injury from the operation itself, and we've completed Virchow's triad: stasis, vessel injury, and hypercoagulability. This triad is the perfect setup for clot formation. For example, consider a 42-year-old woman on birth control pills recovering from abdominal surgery. The top nursing priority is early and frequent ambulation. Getting her up and moving stimulates calf muscles, which act as natural pumps to push blood back toward the heart and prevent clot formation. If ambulation isn't possible, simulate movement with sequential compression devices, leg exercises, and maintain adequate hydration to keep blood flowing smoothly. Patients with limited mobility from conditions like PAD or heart failure face similar risks. Their sluggish circulation further increases stasis. Monitor closely for unilateral leg swelling, warmth, pain, or redness, and implement DVT prophylaxis as ordered, including anticoagulants when prescribed. Remember this key phrase: immobility plus estrogen equals danger, so movement is medicine. Our role as nurses is prevention, keeping the blood moving, reducing stasis, and stopping clots before they start.
Now let's look at how lifestyle changes can significantly reduce the risk of venous thromboembolism, or VTE, which includes deep vein thrombosis and pulmonary embolism. Many of the risk factors for VTE are modifiable, meaning patients can take real steps to prevent it. First, encourage regular exercise. Even simple daily walking or leg stretches keeps blood moving and prevents venous stasis. Patients who sit or stand for long hours should get up or flex their ankles every hour. Next, focus on smoking cessation. Smoking damages blood vessels and increases clotting tendencies. Quitting lowers both clot risk and overall cardiovascular strain. Maintaining a healthy weight also matters. Obesity increases venous pressure and inflammation, while gradual weight loss reduces strain on the legs and improves circulation. We should also teach patients to avoid prolonged immobility. Whether it's during long flights, car rides, or at a desk job, movement every hour is key to keeping the blood flowing. Patients sometimes ask about special diets or supplements, but remember, there's no strong link between specific foods and clot risk. A balanced diet is always healthy, but movement, smoking cessation, and weight management are the real priorities. Here's a practical teaching example. A high-risk patient asks what they can do to prevent a blood clot. The best advice? Stay active, stop smoking, and maintain a healthy weight. These small, consistent behaviors are powerful. As nurses, we reinforce that VTE prevention doesn't stop in the hospital. After discharge, movement, hydration, and, if prescribed, compression stockings during travel can make all the difference. So, the takeaway here is simple. Keep moving, stay healthy, and know the signs of a clot early. Prevention saves lives.
Let's review warfarin therapy, also known as Coumadin, one of the most common oral anticoagulants used in clinical practice. Warfarin works by interfering with the liver's ability to use vitamin K, which is essential for making clotting factors. This helps prevent clots from getting larger and keeps new ones from forming. The most important concept to remember with warfarin therapy is the INR, the International Normalized Ratio. For most patients treated for DVT or pulmonary embolism, the therapeutic INR range is between 2.0 and 3.0. That means the blood is thin enough to prevent clots, but not so thin that bleeding becomes dangerous. If the INR is below 2.0, the blood is too thick, and the patient is still at risk for clotting. If it's above 3.0, the blood is too thin, and the patient is at risk for bleeding. INR monitoring begins within 48 to 72 hours after starting warfarin, and then every few days until stable. Once it's consistent, testing can be done every few weeks or monthly. Let's consider a scenario. A 58-year-old on warfarin for DVT asks what their INR goal should be. Their recent lab result is 2.5. Your response should be, "That's perfect, right in the therapeutic range." This shows the medication is working as intended. Reinforce that Indian rupee levels must be checked regularly, and that consistency is key. Now, from a nursing perspective, education is everything with warfarin. Teach patients to keep their vitamin K intake consistent, not eliminate greens entirely, but avoid sudden diet changes. Review bleeding precautions, soft toothbrush, electric razor, and prompt reporting of any unusual bruising or bleeding from gums, urine, or stool. And always review medication interactions, antibiotics, antifungals, and even deep venous thrombosis and pulmonary embolism. Herbal products like St. John's wort can change the Indian rupee dramatically. One last tip. Warfarin takes several days to become therapeutic and several days to wear off. That's why hospitalized patients often receive heparin overlap. Both drugs are given until the INR is in range. So the takeaway is this. Warfarin management is a delicate balance. Keeping the INR between 2 and 3 minimizes both clotting and bleeding risks. Consistent monitoring and patient education are what make this therapy safe and effective.
Let's look at one of the most critical vascular emergencies you'll encounter, the abdominal aortic aneurysm, or AAA. An abdominal aortic aneurysm is a balloon-like dilation of the aorta, the body's largest artery, caused by weakening of the arterial wall. These aneurysms often develop silently over time and can grow quite large without symptoms. The real danger occurs when they rupture, and when that happens, it's a true life-or-death emergency. Here's what to watch for. The classic warning signs of rupture include sudden, severe abdominal or back pain, often described as tearing or ripping, along with diaphoresis, pallor, anxiety, and a rapid drop in blood pressure. As internal bleeding continues, the patient can become tachycardic, clammy, and may quickly lose consciousness due to hemorrhagic shock. Let's apply this to a scenario. A 70-year-old patient with a known 6-centimeter AAA suddenly reports intense back pain, looks pale and sweaty, and has a blood pressure of 80/50. That is a ruptured aneurysm until proven otherwise. Your immediate actions are to call a rapid response, keep the patient flat and still, start large bore IVs for fluids or blood products, administer oxygen, and prepare for emergency surgery. Every minute counts. Mortality increases dramatically with each passing minute of delay. Now, here's a vital safety reminder for nurses. Never palpate a suspected aneurysm. Even gentle pressure can precipitate rupture. If you observe a visible pulsating mass in the abdomen, your first step is to auscultate gently for a bruit, that whooshing sound caused by turbulent blood flow, and then notify the provider immediately. The teaching pearl here is simple but life-saving. Do not palpate a pulsatile mass. If the patient already has a known aneurysm and begins complaining of new or worsening abdominal or back pain, stop all activity, keep them calm, and call for help. Even moving or standing up can increase pressure in the abdomen and cause rupture. In large AAAS greater than 5 centimeters, surgery is typically planned electively, but once rupture occurs, it's a full emergency. If you're showing the CT image on your slide, point out the open arrow. That's the aneurysm sac. And the solid arrow showing free blood in the abdomen. That white contrast that's supposed to stay inside the vessel is leaking out, and that's what kills patients within minutes. So, remember, recognize early, don't palpate, call for help, and keep the patient still. This is one of those high-stakes nursing moments where fast recognition truly saves a life.
Now let's move into one of the most common and dangerous cardiovascular conditions, hypertension, often called the silent killer. Why do we call it that? Because most patients with high blood pressure feel completely fine. They can live for years with dangerously high readings and no symptoms at all. But during that time, the constant pressure silently damages blood vessels and vital organs throughout the body. The target organs most affected are the heart, brain, kidneys, and eyes. And over time, that ongoing stress takes a heavy toll. In the heart, hypertension forces the muscle to pump harder, leading to left ventricular hypertrophy, the thickening of the heart wall. Eventually, that overworked muscle becomes stiff and weak, progressing to heart failure. In the brain, hypertension is a leading cause of both ischemic and hemorrhagic strokes, as well as transient ischemic attacks, or mini-strokes. In the kidneys, elevated pressure scars the delicate renal arteries, causing chronic kidney disease and sometimes end-stage renal failure. And in the eyes, it damages the small vessels of the retina, a condition called hypertensive retinopathy, which can lead to blurred vision or even blindness. Globally, hypertension affects millions of people and remains one of the leading causes of preventable death and disability. The danger lies in its silence. For many, the first sign of trouble is not a mild headache, but a stroke, a heart attack, or kidney failure. So, when we talk about why we treat hypertension, this is the reason. Uncontrolled blood pressure injures every major organ system over time. The list of complications is long: stroke, blindness, heart failure, kidney disease, peripheral artery disease, and even aneurysms. These are not theoretical risks. They are what we see every day in hospitals and clinics. In fact, high blood pressure contributes to about 40% of strokes, 20% of heart attacks, and over half of new heart failure cases. It is also the second leading cause of kidney failure in the U.S. after diabetes. The good news is that most of this damage is preventable. Treating hypertension early and consistently can reduce the risk of stroke by nearly 40%, heart attack by 20%, and heart failure by more than half. As nurses, our role is to give this silent killer a voice through screening, education, and follow-up care. Encourage regular blood pressure monitoring, medication adherence, and healthy lifestyle changes like diet, exercise, and smoking cessation. So remember, hypertension may be silent, but its consequences are not. Our job is to help patients recognize the danger before it's too late and empower them to take control of their blood pressure, one reading at a time.
Next, let's check into how hypertension damages one of the most vital organs in the body, the kidneys. When blood pressure stays high for long periods, that constant force damages the small arteries inside the kidneys. These vessels start to narrow, thicken, and scar, a process called nephrosclerosis. Over time, this limits blood flow, deprives kidney tissue of oxygen, and slowly destroys its filtering ability. In fact, hypertension is the second leading cause of end-stage kidney disease in the United States, right after diabetes. The early sign of kidney damage is often proteinuria, small amounts of protein leaking into the urine. If blood pressure isn't controlled, this progresses to chronic kidney disease and eventually kidney failure, requiring dialysis or transplant. Once that damage happens, it's irreversible. Prevention through blood pressure control is key. From a nursing standpoint, our teaching should emphasize that treating hypertension protects the kidneys. If the patient also has diabetes, controlling both blood pressure and blood sugar is essential. Together, they are the two biggest culprits behind kidney failure. Encourage patients to have regular creatinine and GFR tests to monitor kidney function and to take their medications consistently. Also, highlight simple but critical lifestyle choices. A low-sodium diet to reduce pressure, avoiding NSAIDs like ibuprofen that strain the kidneys, staying hydrated, and reporting any swelling, fatigue, or changes in urination early. Here's a practical teaching moment. When a patient says, What happens if I ignore my blood pressure? Tell them plainly. Uncontrolled BP can destroy your kidneys and lead to dialysis. That statement sticks. It helps patients connect the dots between prevention and real-life consequences. So remember, controlling blood pressure isn't just about numbers, it's about saving kidneys and protecting quality of life.
Now that we've talked about the importance of blood pressure control, let's discuss how to make sure we're actually measuring it accurately. A key point to remember is that caffeine and nicotine both act as stimulants. When consumed right before a blood pressure check, they can cause a temporary spike in readings, giving a falsely high result. Caffeine from coffee, tea, or energy drinks can raise systolic blood pressure by about 5 to 10 millimeters of mercury for a short time. Nicotine, on the other hand, triggers vasoconstriction and an increased heart rate, both of which elevate blood pressure. That's why guidelines recommend waiting at least 15 minutes, and ideally up to 30 minutes, after a patient has had caffeine or smoked before measuring their BP. This allows those temporary effects to wear off, giving you a true baseline reading. Let's think through a scenario. A patient just finished a cup of coffee and a cigarette, and your aide is ready to check their vitals. What should you do? The correct action is to wait about 15 minutes before taking their blood pressure and use that time to assess other vitals or provide patient education. You can explain that caffeine and smoking can temporarily raise BP, and this wait ensures the reading reflects their actual control, not an artificial spike. Beyond that, remember the fundamentals of accurate measurement. The patient should sit quietly for 5 minutes with feet flat on the floor, arms supported at heart level, and no talking during the reading. Use the correct cuff size. Too small will give a false high, and too large a false low. Also, avoid measuring immediately after exercise or emotional stress, as both can skew results. And here's an important documentation tip. If the patient had coffee or smoked recently, note it in your charting. For example, BP 150/88. Patient had coffee 10 minutes prior. That context helps providers interpret the numbers accurately. So remember, when it comes to blood pressure, accuracy is everything. A rushed or poorly timed reading can lead to unnecessary medication adjustments or missed diagnoses. Take your time, control the environment, and get the most reliable result possible.
Now that we've discussed the pathophysiology and complications of hypertension, let's look at how we manage it pharmacologically. There are 4 major classes of first-line antihypertensive drugs to remember, and you can use the easy mnemonic ABCD to help recall them. A for ACE inhibitors or ARBS, B for beta blockers, C for calcium channel blockers, and D for diuretics. Let's start with diuretics, such as hydrochlorothiazide or furosemide. These drugs lower blood pressure by decreasing blood volume. They help the body eliminate excess sodium and water through urine. Think of it as reducing the water in the pipes, which lessens pressure on vessel walls. Nursing reminders: monitor electrolytes, especially potassium, and assess for signs of dehydration. Hypokalemia can cause muscle weakness or arrhythmias. Next, ACE inhibitors like lisinopril or enalapril. These drugs block the conversion of angiotensin I to angiotensin II, a potent vasoconstrictor. The result is vasodilation and lower vascular resistance. They also reduce aldosterone, promoting mild diuresis. A key side effect to remember is the dry, persistent cough caused by bradykinin buildup. If that happens, the patient may be switched to an ARB such as losartan, which works similarly but without the cough. Calcium channel blockers like amlodipine or diltiazem prevent calcium from entering cardiac and smooth muscle cells. This relaxes arteries, reduces afterload, and in some cases slows the heart rate. Patients may experience ankle swelling or constipation, especially with certain CCBs. So, patient teaching about fluid intake and leg elevation is important. Beta blockers, such as metoprolol or atenolol, block beta-1 adrenergic receptors in the heart. This slows the heart rate and decreases contractility, leading to lower cardiac output and blood pressure. However, we need to monitor closely for bradycardia, fatigue, and orthostatic hypotension. And here's a critical safety point. Never stop a beta blocker abruptly. Doing so can cause rebound tachycardia and severe hypertension. Always taper under medical supervision. Before administering any antihypertensive, always check the patient's blood pressure and heart rate. If the systolic BP is below 100 or the HR is below 60, hold the medication and notify the provider. Be mindful of fall precautions, since these medications lower pressure and can make patients dizzy when standing up quickly. It's also worth noting that certain drugs work better in specific populations. For example, diuretics and calcium channel blockers are particularly effective in African American patients, while ACE inhibitors are especially protective for diabetics because they help preserve kidney function. So, the key takeaway is this: don't just memorize the drug names. Understand how they work, what to monitor, and how to educate your patients. When you understand the why, the what becomes much easier to remember. Also, one of the biggest challenges in managing hypertension isn't finding the right drug, it's making sure patients actually take it. The main cause of uncontrolled blood pressure is non-adherence, meaning patients aren't taking medications as prescribed. Nearly half stop within the first year, often because of barriers like side effects, cost, complex regimens, or simply forgetfulness. Some patients also think, I feel fine, so I don't need it, since hypertension is often symptom-free. As nurses, our first step is to assess adherence non-judgmentally. Instead of asking, you're taking your meds, right? Try, many people have trouble remembering pills. How often do you miss a dose? That opens honest conversation. Then, tailor solutions. Switch meds for side effects, find generics for cost, simplify dosing, or use pill boxes and alarms for reminders. Always document if adherence is an issue so providers can adjust therapy. Here is one more key message: adherence is a partnership. When we listen and problem solve, we empower patients to take control of their blood pressure and their health.
Let's talk about one of the most common side effects we see with antihypertensive medications: orthostatic hypotension, or a sudden drop in blood pressure when a patient changes position. Beta blockers, like metoprolol and atenolol, are widely used for hypertension, but they work by slowing the heart rate and reducing cardiac output. In older adults, this can blunt the body's normal compensatory response to standing, meaning the heart can't speed up quickly enough to maintain blood flow to the brain. The result? Dizziness, lightheadedness, or even fainting, which can easily lead to a fall. So what do we teach our patients? Always emphasize safety with position changes. Instruct them to rise slowly. Sit at the edge of the bed for a minute, then stand up gradually while holding on to a steady surface. Avoid bending over suddenly or taking hot showers right after taking the medication, as both can worsen dizziness. If a patient reports feeling dizzy when standing, remind them to sit back down immediately and wait for the sensation to pass. They should also keep pathways clear of obstacles and use assistive devices like canes or handrails if needed. For reference, orthostatic hypotension is defined as a drop of 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic within 3 minutes of standing. But even smaller drops can cause symptoms, especially in frail or dehydrated patients. We can also give a few extra safety reminders. Stay hydrated, avoid alcohol, and let the provider know if dizziness or fatigue becomes severe. Sometimes the medication dose can be adjusted or a different class prescribed. And remember, this rise slowly teaching isn't just for beta blockers. It applies to many antihypertensives and vasodilators. Our goal as nurses is simple: keep patients safe while their bodies adjust. Preventing one fall can prevent months of recovery, or worse.
Let's wrap up by reviewing lifestyle modifications, which are the cornerstone of preventing and managing hypertension and cardiovascular disease. Encourage patients to exercise regularly. Physical activity strengthens the heart, improves circulation, and helps lower both blood pressure and cholesterol. Avoid smoking, as nicotine damages blood vessels and increases plaque formation. Maintain a healthy weight, since excess body fat increases strain on the heart and raises blood pressure. Limit sodium intake to reduce fluid retention and pressure within the vessels, and limit alcohol, which can elevate both blood pressure and triglyceride levels. These healthy habits not only prevent hypertension, but also directly protect against complications like stroke, heart attack, and kidney disease. Now let's connect these behaviors to cholesterol management. Hypertension often goes hand in hand with high LDL cholesterol, or bad cholesterol. Elevated LDL contributes to atherosclerosis, which hardens and narrows arteries, worsening blood pressure and cardiovascular strain. For patients with hypertension, we monitor lipid panels regularly as part of comprehensive care. Targets are typically LDL below 100 milligrams per deciliter, or below 70 milligrams per deciliter for high-risk patients such as those with diabetes or established heart disease. To manage LDL, encourage a heart-healthy diet, low in saturated fats and high in fiber, along with consistent exercise and, if needed, statin therapy. Remind patients that managing cholesterol isn't separate from managing blood pressure. Both share the same goal: keeping the arteries open, flexible, and healthy. So the takeaway message is simple: move more, eat smart, quit smoking, and monitor your numbers. Controlling lifestyle factors and cholesterol together gives patients the best chance at preventing long-term complications and protecting the heart.
Let's wrap up our discussion with a foundational nursing skill: dosage calculation. Accurate medication calculation isn't just about math, it's about patient safety. Remember to keep your units consistent. Convert grams to milligrams or milligrams to micrograms when necessary. And always label your work clearly to avoid errors. A quick tip: if your math says to give 20 milliliters of something meant for an injection, stop and double-check. Your calculation or the order might be wrong. Before giving any medication, verify the 5 rights of medication administration: the right patient, drug, dose, route, and time. And don't forget the 6th right: documentation. When in doubt, always have another nurse verify your math, especially for high-alert medications like insulin, heparin, or opioids. So, the takeaway here is simple but vital: never rush your calculations. Accuracy isn't just good practice, it's what keeps your patients safe and builds trust in your professional judgment as a nurse.
To close, let's review the essentials. Peripheral arterial disease, PAD, means pain with activity. Plaque buildup narrows arteries, so walking causes cramping that eases with rest. Teach patients to join interval walking programs. Walk, rest, repeat to improve circulation. Encourage smoking cessation and daily foot checks, since poor perfusion increases ulcer risk. And remember, no compression stockings unless ordered, because they can worsen arterial ischemia. Chronic venous insufficiency, CVI, means relief with elevation. Teach patients to elevate legs, walk daily, and wear graduated compression stockings applied smoothly each morning to prevent swelling and ulcers. Hypertension, HTN, is silent but deadly. It damages the heart, brain, kidneys, and eyes long before symptoms appear. Accurate BP checks, medication adherence, and lifestyle changes save lives. And finally, our nursing role: prevention, protection, and education. We teach movement for arteries, compression for veins, and control for pressure, empowering patients to protect their circulation and live healthier, longer lives. Thank you for your attention, your dedication to patient safety, and your commitment to compassionate, evidence-based nursing care.